Thank you very much for this honor to speak here. It's really a pleasure to be in Lisbon. It's always a very nice city, and I see it's so prosperous. So it's really a pleasure to be here and to show our experience with HCV and the Vela system. So what you see here is a picture of the port of the University Hospital. This is the official photo that we have to take. That, well, if you visit us, it looks a bit better than this. So coming back to the topic, epidemiology of HCV, you have seen the data already. There is quite a divergence of the estimated number of HCV cases worldwide, but for pretty sure we can estimate 80 million people infected with HCV. For Germany, we estimate a number of 300 to 500,000. So we are not in the dark blue region as we just saw. So we are in a lighter in the green region already. Nevertheless, we have so quite a low prevalence in Germany compared to other countries. The mean age of first diagnosis is between 25 and 39 in Germany. We estimate a number of 300,000 replicative infections. So those are the ones displaying HCV RNA. And this is a graph showing the annual report of newly detected HCV infections. That does not mean these are acute infections, but these are detected newly. So we have an average number of at least 5,000 patients detected every year with HCV. You have seen this picture already. Compared to HIV, from which we know that it is highly divergent, HCV is even more divergent, and to make it even more complicated, we have not only genotype 1, A and B, but we also distinguish between clade 1 and clade 2. That was not interesting before some specific drugs came to the market. We'll come to that later. Worldwide, genotype 1 is the most prevalent one. 1B to be a bit more prevalent than 1A. And when we discuss the genotyping, this is what already quite old report here from 2002, and it reports a recombinant. So when you do the genotyping in this region, in the 5' region, you find that it is a 2K. But when you do the whole genome, sequence the whole genome, you find out it's 2K here and 1B there. So you have a discrepant result. And the question is not, like also other recombinants reported here, what is the correct genotype? This is not really interesting because, going back to this slide, the targets of the therapy are in this region, which is a 1B. So if you correctly type this as a 2K in this region, this is not good for the prediction of the therapy. So what you should know is that the targets of this virus is a 1B. Okay, so then we have a number of other recombinants. Actually, we do not really know how many recombinants are circulating because we either genotype here or we genotype there. So we miss the recombination in most of the cases. It is important to know the genotype. So this is accepted by all clinicians because depending on the genotype, we have different strategies for therapy. I think we are going to have an update soon because this slide does not include velpatasvir yet. What does it mean to the treatment in Germany? So what you see here is the black bars are the PEC-RIBA combination therapies, and this is going down. But still, to my surprise, we still have a number of PEC-RIBA combination therapies in Germany, but they are more and more replaced by the direct acting antivirals. As you see here, the list of different drugs combinations. So, coming back to what can we do as virologists, people from the lab, there's an simiprevir, this is an NS3 inhibitor by Janssen. there was a recommendation for Q80K screening. And this subtype, or this Q80K, occurs almost exclusively in clade 1 of subtype 1A. So if you do a simple genotyping and find it's a 1B, then you can use imipivir. If you find it's a 1A, then you should see what clade is it and does it carry the mutation. So this is the relevance for this NS3 protease inhibitor. The other drug that made it to the market now is the combination of NS3 inhibitor plus NS5A inhibitor called Sepatier. And the FDA and the Swiss recommendations say if you have a genotype 1A plus a number of baseline NS5A polymorphisms, then you should extend the treatment to 16 weeks. So there's a clear correlation between typing and therapy. Then we have a list of good drugs now available. And those who are not really familiar with these drugs, those who end with Previr are the NS3 inhibitors. Those who end with Asvir are the NS5A inhibitors. And those who end with Buvir are the polymerase, the NS5B inhibitors. There we have two different. The one is in the regimen of AbbVie, and the other one is the Gilead component, Sofosbuvir. Oops. And not all drugs can be applied to all genotypes. So this is still a problem that is not really solved yet. We have seen that already from Christoph Rodriguez data. So we have genotype A, genotype 1, this is the most prevalent, and all the drugs have been, in fact, developed for this genotype. Genotype 2 doesn't look so promising with the different options. Genotype 3 is a major problem, and genotype 4 is a bit easier. But we see that not all drugs can be applied to all genotypes. And all the drugs develop different resistance mutations. And to make it a bit more complicated here for the position 30, it is not in every case Q or R, the resistant variant, but it depends on the genotype. So you need an interpretation system that knows what genotype is it, and in case it is this or this genotype, this position is Q or R, the resistant variant. So then there are some resistance mutations reported for the other drugs. Okay. So when you look on the study with Sofosbuvir and Daclatasvir, then you see, okay, it is not good. It's not very good if you have a cirrhosis. Then the chance of therapy success is lower. But what is been a bit underreported in this paper is the fact that this mutation plays a major role. And in fact, the prevalence of this mutation baseline is already 8.8% in this group of patients. So the prevalence of this mutation, genotype 3, is quite high. So what we did is we started our PEPSI project. That means we started to collect data from the EU, and we do genotyping and resistance testing. So we develop protocols and we provide protocols to interested groups, and we developed the Genotofino HCV resistance interpretation system. So collection of data. This was a period where these data were generated from 2011 to 2015, and with HIV and HBV co-infections, or simply, mono-infected HCV. I shouldn't say simply. So this was a data collection all over Europe, and including South Russia. These are the raw data. We collected almost 40,000 records in 52 centers over that time. And now, what is the outcome, the summary of that? Here we see the Los Alamos database, the Los Alamos data that we have access to, everyone has access to, and can see what data are there. We see the majority here reported is 1B for Germany. So I should say these are the data for Germany in the Los Alamos database. Majority is 1B. And now have a look to the real data. So we have less genotype 1 as reported in Los Alamos, and we have less 1B as reported in Los Alamos database, and we have quite a number of genotype 4 coming up. Genotype 4, for those of us who do not enter these clubs in Berlin, London, Paris, for having sexual intercourse unprotected, so you can get the genotype 4 there. Okay, so in contrast, we have more non-Bs as reported in the Los Alamos database. So this is open access. You just paste in your sequence, your FASTA file here into the Genotypheno tool, and you get your raw data and a prediction, interpretation of what you see, the where you sequenced and what genotype is predicted, and if it is susceptible to those NS5A drugs, here marked in green. Okay, this is a PDF printout that you can generate, and also what you can look at is the rules that are behind the system. And meanwhile, we have a large group of virologists in Germany, including the HIF grade team, and clinicians from Düsseldorf and Siena in Köln involved in that, and the group is steadily growing. So, baseline resistance. When we collect the samples in Germany, this is the raw data, and this is the summary slide. This means that depending on your target, NS3, NS5A, and NS5B, that we have a decent number of baseline resistance mutations. And this is especially a problem for the NS5A region. NS5 inhibitors are the backbone today of every combination therapy. So you have an NS5A inhibitor plus a second drug. And as we later see, it has been already very intensively reported that these mutations do not go back over time, so they persist. Okay, one case report. These are the data from the patient. So he was infected with HCV, and so they already fibrosis. No, that's not a good sign. It's difficult to treat patient. And then he started 3D ribavirin treatment for 12 weeks. And after week 4, it looked good. But at week 12, at the end of therapy, he had a relapse. So what happened? So this is the baseline picture we see with 3D. This is three target regimen. We already see that the NS5A region was resistant, that there was a resistance in NS5B to the 3D combination, and the only working drug was the NS3 inhibitor. And by the time this became also resistant. And what you see here is that these mutations in NS5A persisted, and he developed over time an additional resistance to the fosbuvir, here in yellow. So he acquired a mutation which is reported with resistance to the fosbuvir. We do not know what clinical relevance this means, but just to treat this patient with the fosbuvir is really risky. So, Christoph, you are in the lab. What is your in the clinics? What is your opinion? Is this a good idea now, just to try the fosbuvir in this case, or rather wait for a new combination therapy?
Well, I think in this case, fosbuvir could be maintained.
You wait, huh?
Yeah.
For a new combination. Yeah. So this is what happens to this patient at the moment. But remember, he was an F4 cirrhosis patient. So, sorry. So he's really in danger, and he needs treatment. So what happens with resistance-associated substitutions, variants, or mutations. There are some different expressions circulating. The best expression I heard was to call it RATS. It was resistance-associated troublemakers instead of variants or mutations. So what happens over time? We have a selection that selects these variants over time, and the NS5A resistance mutations persist even if you take off the drug. And we have a high risk of persisting NS5A resistance mutations. So, as I hope I could make clear that there is a need for a proper diagnostics. And for that we have the Vela system. You have seen these slides here before. So just showing the different features of the system. This is all three regions are analyzed in this detection mode. And we have a very nice reporting. So this is filling the flow cell, the analysis. Then you get a quality report. So what happens? Is this a good thing? What happened there? Quality is, I think, sometimes underestimated. At least when you run into trouble, then you go back to your quality report and see what happened. Then you have a pathology report. That means how to interpret what comes out. But you also get, in detailed results, the raw data. And since a few days, we have the chance and the opportunity and the feature to use the faster export so that we can feed additional interpretation systems. So this is an open system, and I would say this was really a good work from Vela to react so fast. So then we compared our in-house system. As you remember the talk from yesterday from Martin Däumer and Alex Thielen, we are using an in-house PCR and the analysis on the MySec system. We run 87 samples, and we had 79 of those with concordant results. So here you see the distribution, genotype 1, 2A, 2, and 3, genotype 4. And what about the discordant samples? So we had 2 of the 8 Vela negative, in-house positive, 1B, the other one 3. Then we have 4 samples the other way around. And 2 of the 8 were concordant, but Vela could additionally detect a 3A in these 2 samples. So we have 2 patients that had a multiple infection with 2 HCV genotypes. So now into details, concordance of specific mutations. So very important, this 93H mutation, as you remember, this mutation kills almost all of the NS5A inhibitors, including the novel Patosvir. There we had 5 samples concordantly, but 2 samples additionally in-house. And here we should mention that the interpretation report, is only given for genotype 1 and not for 2 to 6. But as I just mentioned, we can use the FASTA file and address an additional interpretation system. So the positions exclusively for NS5A mutations, here 31, 28, and 30. Here we have 2 detected in both systems, 1 detected in each system, but in different samples. So both overlooked 1. And here we have 1 genotype 3A resistant variant only detected in in-house system. And those discordances are mainly due to the fact that those are not scored in the Vela system. They have not been overlooked, but they are not scored. NS3 mutations, this is just 1 that was missed, but the other 4 were concordant. And here I wrote it here that the faster export is now possible for a few days. In total, positive rate by region. So NS3 region, genotype 1, in-house, we had 57% detected, and with the Vela system, some more. So there's really a strength in the system detecting the NA3 region, and a slight improvement for the NS5A region. So what is going on? I think we have an up-to-date system to predict genotype, to analyze the sequence, and to make interpretation, a baseline interpretation for the patients. And now the team of Vela is improving the feasibility that we also can use the additional information of next generation sequencing. Christoph showed that this is a good and an added value for HCV treatment to look on the minorities. So, summary, the HCV genotype analysis by sequencing, this is my opinion, that this is the up-to-date system. We should not discuss going back to point mutation assays and detect those, however. And very important to determine the treatment relevant region of the genotype, for the genotype. Second is resistance mutations occur before baseline, and optimized therapies can be selected based on this baseline detection to avoid not fully active drugs, but to make therapy combinations for those patients who already have an impaired virus system, a virus with less susceptibility to the drugs. So we can select a better regimen and replace the non-working drugs. This is also a cost. I mean, why should you administer a drug which is not working? It's just costly. So, and very important, now this is the first commercial assay based on sequencing for many, many years, since I think March last year. The two-gene sequence-based genotyping system was withdrawn from the market, and since then nothing happened. And on the HIV field, we have not spoken about HIV today, but the HIV, most of the analysis in Germany are done with in-house systems, but it is very important to have access to commercial systems that we enable a broad accessibility to that. And in fact, in Germany, all the clinicians who want have access to a sequence-based analysis. They just have to address their lab, and within the network we can enable the sequence analysis. So we have facilities in Frankfurt, and all the 12 different if-grade labs can perform the sequence analysis. So this was not possible without these people that I mentioned here. Especially I would mention Elena Knobs from our group, who did all the analysis of the data that you have seen here, and all the other people in our lab. This is, by the way, our institute, nice villa at the Stadtpark in Cologne, with the help of the people from Vela Systems, clinicians from Düsseldorf, Institute of Virology in Düsseldorf, the bioinformaticians, and the people from Eurasist to coordinate also our ideas all over Europe, and to provide the knowledge from that group. So this is my obrigado.